In this video about hyperpigmented lesions, we're going to talk about cancer, but for the most part, we're going to talk about things that aren't cancer yet or aren't going to be cancer. In the subspecialty surgery videos, skin cancer is where we go after the actual malignant lesions. These are going to be a discussion of the lesions that could be cancer but aren't, or could be cancer and aren't yet cancer. So to start off first with the thing that looks like a melanoma, which is a mole. Moles are benign lesions and they come from melanocytes. So when you see a mole, you have to ask, is this thing melanoma? And you want to know that because the sooner you diagnose melanoma, the better the prognosis is. You do not need to know the different subtypes of nevi. Just recognize that a mole is a mole and doesn't need to be biopsied. Does it need to be biopsied if you see hair in the mole, it's benign. But what you're trying to do is rule out melanoma. And so we use this opportunity to introduce A, B, C, D, E. And the idea is, if you are positive for any one of these, consider it melanoma and get a biopsy. If you are negative for all five, you can consider it a benign lesion, follow it over time. A stands for asymmetry. B is borders, and that is if the borders are irregular. C is for color, that is, it's not uniform, mixed colors. D is diameter, greater than 5 millimeters. And E is evolving, that is, any one of these is changing over time. If you have all five negative, you do nothing. You leave it alone. It is a clinical diagnosis, and if they want it removed, it would be for cosmetic purposes only. Compare that to seborrheic keratosis. You have to be careful here with the vocabulary. Seborrheic keratosis, therefore a lesion of keratinocytes. This is also benign. Benign keratinocytes. This is a thing that looks like squamous cell cancer, but isn't. Seborrheic dermatitis was the thing we talked about in the scaling lecture, where you have scalp and eyebrows. Seborrheic dermatitis, this is seborrheic keratosis. Seborrheic keratosis is just a marker of aging. It's benign and it's made of keratinocytes. It's going to be large, greasy, and it looks stuck on. What does stuck on mean? It looks like someone just picked up someone off the ground, rubbed it in some glue, and stuck it on someone's face. It doesn't have interconnections with the surrounding skin. It does, it just doesn't look like it from the outside. So the thing you have to do here is ask, well, what's the chances that this large, nasty thing that's A, B, C, D, E positive is a cancer? Well, if that person has had it for a long time and it's stable, you don't have to do anything, it's clinical, and you're done. But if it's new or if it's changing, that's a delta, then you need to do a biopsy to rule out cancer. And just like moles, these things can be removed if the patient wants it so. The disease that is keratinocytes related, that is not benign, is actinic keratosis. Actinic keratosis is a premalignant lesion of keratinocytes. What you're looking for on the vignette is there an erythematous lesion with a sandpaper-like scale. And that scale will be yellow to brown. And sandpaper scale is the buzzword you're looking for. What they're saying is this is a premalignant lesion. If you see sandpaper scale anywhere about a hyperpigmented lesion, think this could be squamous cell carcinoma. Now, if they want you to go down the route of skin cancer, they're likely to give you a history of sun exposure. And they're going to do that in the way of occupation or lifestyle. Very rarely do they give you an occupation. So when they say something like a farmer, construction worker, or someone in the Navy, what they're implying is they've had increased exposure to sunlight. If they had an early burn, or they have life on an island, like they're a surfer in Hawaii, then they might have increased sun exposure. So the people who have this increased sun exposure and have the sandpaper scale, they need to get a biopsy, because it's probably going to be premalignant, and if it is, you can treat with cryoablation. Just freeze it off, and you can use 5-fluorouracil to back it up to get any residual. The idea is that once cancer gets out of the basement membrane, now it grows big and nasty. This is full-on squamous cell carcinoma. Carcinoma in situ is the entire epithelial layer being replaced by malignancy. This is Bowen's disease. Actinic keratosis is like only a layer. It's not even as big as Bowen's disease. And this is a continuum of the same disease leading to squamous cell carcinoma. So if you find actinic keratosis, you need to treat it. You will prevent it converting into cancer. Since we're talking about it, squamous cell carcinoma is the malignant lesion of keratinocytes. What you're looking for is skin, right? They're keratinocytes. So you want to look for a flesh-colored lesion. It's usually that has an ulceration. Something is different about the skin. Even though it's the same color, it's not doing quite the right thing, like has an ulcer. And of course, because it's cancer, we're going to get that sun exposure again in the vignette. To diagnose it, you get the biopsy, and treatment is resection. Unlike basal cell, squamous cell carcinoma can metastasize. So you do want to be aggressive with the operation. And if you see anything about a lip, squamous cell carcinoma is going to be on the lower lip 90% of the time. But this wouldn't be that hard if this is all there was. There's also this thing you need to consider, which is called keratocanthoma. And a keratocanthoma is essentially squamous cell carcinoma, except it spontaneously resolves in 6 weeks. So if you have someone in front of you with a lesion that looks like it could be cancer, you're going to biopsy. Even if it is keratocanthoma going to go away on its own, in the moment you can't tell which one it is. But if someone told you about, I had cancer, it got better on its own, it was probably a keratocanthoma and not a malignancy. The last one, we put it in here, not because it goes along with skin cancer, but because it is a hyperpigmented lesion that you do have to know about, and that is Kaposi sarcoma. The path is infection with HHV8. The patient must be immunosuppressed, and that is in the way of AIDS, and they will present with a purple lesion. This is a very vascular lesion, and so biopsying it will cause it to bleed. You don't have to diagnose it with a biopsy, because if they're immunosuppressed and they have the classic features, then it's a clinical diagnosis. In general, if you treat the HIV, that is, you start retrovirals, you put them on heart, their CD4 count rises, these lesions generally go away. If they don't, then you do have options for local, that is like injection into the lesion itself, or systemic chemo, depending on how bad it is. We're talking about it in skin cancer because it is a hyperpigmented lesion that can be a distractor for the others, but Kaposi sarcoma is this vascular lesion that can happen anywhere: mucosa, internal organs, skin, etc. Okay, so to review, it could be melanoma. That's what that mole is for, A, B, C, D, E. It could be squamous cell carcinoma. That's what seborrheic keratosis is for. These are not cancers, they are benign. But as you get sun exposure, you can turn into actinic keratosis, which is a pre-malignant lesion on its way through Bowen's disease to full-on squamous cell carcinoma. Biopsy and resect. Don't forget about keratocanthomas, the squamous cell carcinomas that got better on their own, and Kaposi sarcoma, the thing that HIV/AIDS patients get as a hyperpigmented lesion that's purple. That is hyperpigmented lesions.